Hello, my name is Stephen Rowley and I'm a patient advocate. I do what's known as PPI, Public Patient Involvement in the NHS, in research and in development, in policy, co-creation, co-production of services and therapies. So what has PPI got to do with IT in the NHS? Well, let's go back a bit. I've had a colourful career spanning science, research, engineering, R&D, marketing and the arts. Along the way, I was a senior executive in the second largest computer company in the world and played a role in developing the security and authentication that you use every day in the internet. In 2015, I was planning my last few years in the field of creativity in education when I was diagnosed with stage 3 colon cancer. In 2018, my brother Damon was diagnosed stage 4 and died from the disease. Subsequently, I found myself with a whole new career in patient advocacy. My diverse background has proved valuable, bringing transferable skills and experience to my work in the NHS and cancer research. Now, we all know that IT has tremendous benefits for the NHS and for the patient. In March 2020, I saw a need for a different kind of peer support group and set up the online Bowel Cancer Support Group UK on Facebook. It was particularly appropriate for patients during lockdown when face-to-face support was not available. However, its benefits were not just for COVID. We now have over 5,500 members, a large team of moderators and a management team overseeing the operation, and a number of our members who are also professional clinicians to call on to help us keep on the straight and narrow. It's an operation that provides 24/7 support, and I find it quite interesting to log in the morning and see the discussions that happen between the people who are wired and wide awake because they're on steroids for their chemotherapy at 3 o'clock in the morning. I'm very pleased to see how patients are benefiting from the growth of digital innovations. Aside from the technical advances in diagnostics and treatment, we are seeing EIT provide improved communication with clinicians and administrators. Better access to the information about services and procedures, access to electronic health records, remote consultations without having to visit surgery or hospital, and support from clinical and peer sources. In the bigger picture, there are further developments that are benefiting patients. Apps are helping people manage their condition. Telemedicine allows people to be monitored at home in virtual wards. And clinical trials with virtual control arms so that everyone on the trial is getting the novel treatment and nobody has to be on the control arm. More abstractly, the public and patients are benefiting from research using big data, biobanks and AI to optimize diagnostic tests or treatments or identify risk factors, genetic biomarkers, etc. Now, I'm involved in lots of different kinds of research. I'd like to share a couple of examples from Europe. Firstly, Guide MRD. This is an ambitious project to set up large-scale trials across Europe of liquid biopsy sequencing of ctDNA for monitoring minimal residual disease in cancer patients. This is a technology that's revolutionising aspects of cancer treatment, helping to decide which stage 2 or 3 patients would benefit from adjuvant mop-up chemotherapy and which would benefit from not having it. By establishing a commonality amongst the various trials across Europe, we will gather experience in the best way to implement the technology in clinical practice. It will also generate a massive amount of sequencing data that will be available to bona fide researchers to optimize the method and observe other potential benefits in diagnostics. A key aspect for us patients who are involved in the design and implementation of this project is the way the data is managed. We want our data to be used for bona fide research that brings clinical benefit. This is data that is managed appropriately with due attention to confidentiality, to ownership, including the ability of patients to withdraw their data, transparency, and it is pseudonymized so that researchers cannot trace it back to the individual, but if there is clinical benefit, the hospital treating the individual can actually take that benefit back to them. Approved researchers are not allowed to download the data. This is not data that will be bought and sold. The researchers can upload their research questions and algorithms into the research data space. Another project is EOSC4 cancer. This time, not connected to just one type of diagnostic or trial. This is a giant project for establishing common rules and principles to establish a framework for all DNA sequencing data across Europe. DNA biobanks on an enormous scale to make the best value of the sequencing that's happening all the time and will increasingly happen. Again, there is full patient involvement in the project from design onwards, ensuring security, confidentiality and transparency. A different kind of project is Smart Care. This is patient-facing. It's a European cancer survivorship app providing many different kinds of support, information and communication for patients during and after treatment. Now, I'd like to point out that these major software projects are responsibly managed and have built-in quality assurance and patient oversight. PPI is at work in the IT of health. Now, apps. At this very conference last year, I sat in the audience and saw a series of clinical consultants introduce their fabulous new apps to provide benefits to patients in managing their disease. So important were these projects to the consultants, they had scaled back their clinical role to 1 or 2 days a week in order to spend more time on their spin-off app software companies. I was interested to find out just how did this work? What's the financial model for these apps? They're free to the patient, free to the healthcare provider, the hospital or the clinic. So how are they funded? How does it compensate for the loss of earnings when you scale back from doing your clinical work? Well, the answer lies in the click. The patient has to click to allow us to use your data in research. Click to allow us access to your health records. The financial model for these apps is to sell data to pharma. We're talking about millions. A pharma company is prepared to pay a huge amount for a small data set. In fact, the smaller the data set, quite often, the more it's worth. Data sets for rare diseases are worth a huge amount. And we are talking millions. There is an example of an institution in New England that collected a data set from just 27 patients with a rare disease, and they sold it for 23 million. This is not what the patient is agreeing to when they are in the care of the HNS and they're given an app to help them manage their disease. They click to allow their data to be used for research, but they are expecting it to be for bona fide research and not for the pockets of the consultants. Very different from my experience in Europe. Data ownership and transparency is not my only area of concern. At the conference last year, it was quite clear that most of these app developers have no understanding of quality assurance or safety in software design. It was quite clear that many of the consultants and developers had not a clue about software's quality assurance and safety. These processes are normal in product development and accreditation. You could not supply software to the nuclear industry or an airline without conforming to international standards and quality assurance. This is for public security and safety. So what makes healthcare so special that it can ignore these measures? The humble Hewlett-Packard diagnostic equipment, or the machine that drives the pump, will have software in it that has been designed and accredited to meet certain software quality assurance standards. There's more quality assurance in a simple data recorder than there is in all of these apps put together. So who is benefiting from my data? With a total lack of attention to quality assurance, safety and transparency, it appears that the apps are really intended to improve the bank balance of the consultants who code rather than the patients and the public who are wanting to use the apps. The patients are being taken for a ride. Patients want their data to be used to benefit society, and they expect the app to be of high quality and proven safety. This requires patient involvement in the development and implementation of IT solutions in the public health sector right the way up, including apps. The implementation of public apps in the NHS at the moment is more like the Wild West. It looks to me like an area that needs regulation and fast. Across the channel, they're introducing a Europe-wide health technology assessment process. I think all apps should be considered to be medical devices and conform to common standards of quality assurance, safety, etc. So stop playing fast and loose with our lives and our data. Thank you.